The next case is a case of a female patient, 63 years old. She complains of yellowish discoloration of skin and sclera. CT abdomen reveals pancreatic head mass with CVD dilatation, bone metastasis, L1 vertebral body osteolytic lesion. ERCP 11/2019 was done with failure of scope to pass to second part of the duodenum due to the mass infiltration. EUS guided choledochoduodenostomy was done with insertion of partially covered metallic stent. The patient is for EUS gastrojejunostomy.
Okay, good.
Hello,
Okay,
Professor
where is
Manuel.
the- okay, the
I am Mahmoud Al Ansari with you, and fortunately, your case has been now in my session because it was in the second session, so it is postponed in my session. Thanks. So we are waiting for your
Okay.
interesting case.
Okay, so we are here with a wonderful team at the Air Force Hospital, very helpful people whose names I'm sorry I can't pronounce or remember, but I'm very thankful for what we've done so far, which is not a lot. We've only passed a guide wire through a duodenal lumen stricture. If you remember from this morning, this case is very similar to Professor Giovannini. It's unresectable, locally advanced pancreatic cancer with both combined biliary and duodenal obstruction. However, the approach to palliation that we are taking is slightly different, or I would say completely different. Instead of luminal stenting in the bile duct and in the duodenum, we are doing transmural bypass, EUS guided. You see the stent, what are you seeing is the endoscopic view. You see a biliary covered metal stent coming through the wall. This is not the papilla, this is the duodenal wall above the papilla. This is a choledochoduodenostomy stent, which is working very well. The patient has no jaundice. So we are bypassing the papilla. It was done before, a few days before today. And now we want to do the same thing to the stomach. We want to bypass the stricture into the duodenum, the very distal duodenum beyond the trites ligament. So can we have fluoro, please? Can we have the screen? So you see the tip of my endoscope. This is a duodenoscope. Is in the bulb, right where the choledochoduodenostomy. I can go a little bit backward. So you see this is the bulb. This is the bulb here. This is pylorus, right? We're in the stomach. I go across the pylorus and come at the apex of the bulb. There is the choledochoduodenostomy. Then I have the lumen of the duodenum with a standard 0.035 guide wire and a standard ERCP wire, and I'm going to ask Salma to pull on the guide wire, and I'm push a 7 French nasobiliary catheter. So Salma, please pull on the wire a little bit harder. So you see this is a 7 French nasobiliary catheter, and we're going to see on fluoro. Now, it is at the second duodenum between the junction between the second and the third. I'm going past the second, into the third, and I'm taking now on the fluoro, you can see the trites ligament. This is where we want our gastroduodenostomy to be, at the trites ligament. So I'm putting this catheter here so that I can instillate fluid real time while I am under ultrasound view. So I will gonna pull out backwards from the stomach while I leave the catheter in place. So I'm removing the duodenoscope. Dr. Blero is being very helpful, just to be careful not to have a lot of traction. So I'm keeping this under fluoro. You see it's moving the gastric part of my 7 French nasobiliary drain. Okay, so sorry, hold on, Daniel.
Yes.
Wait.
I have it.
Yeah, we need to remove the, can you show my hands? We need to remove this. Watch out. You know the nasobiliary fluoro, please?
Professor
Screen.
Manuel, what is the aim of this nasobiliary catheter, please?
You see, the catheter is called nasobiliary. It's a wrong name. It's orojejunal, oroduodenal, because it's coming through the patient mouth. And that is a very important question. Why do we need a catheter beyond the luminal stricture before placing a stent? Hold on one second. We need to remove this, and now we need the EUS ultrasound linear scope. So the reason is, we're in trouble.
It has already moved.
Yeah, it has moved away.
Okay, maybe we still have the wire in place. Maybe we can try to advance it.
No,
No?
it will not go through. We would just, so the catheter is to be able to image the, no, we need to do it again. So you'll
remove
see
everything?
yeah, pull it out. Remove the wire, give me the oasis. The oasis, flash it and put the wire through the oasis. We have miscoordinated during endoscope removal, and the nasobiliary catheter has come out from the distal duodenum. So we have to go back again
Yes. And
through the
scopic picture,
duodenal.
please.
So what are you seeing is now duodenostomy stent, duodenal lumen. We have to make the guide wire go past this stricture. Okay?
We have fluoro. We have.
Yeah, make it go. Make it go.
Yes.
Can you make the guide wire go through,
Can
please?
you push? Yeah.
You have resistance. Okay? I'm
Yes,
pushing my
yes.
side viewer a little bit deeper.
You're deep. You reach the traits almost.
Put the wire in, please, Salma. So we are just like we began. Push, push, push. Do you have resistance? Are you good?
That's better.
So, yeah, it's okay. That resistance is okay. We're going to loop the wire. There's a little bit of resistance. We're going to create a few loops to prevent dislodgement during catheter exchange. I'm going to exchange the catheter that I use for guidewire passage. Is an 8.5 French Oasis stent introducing catheter.
Yes.
The tip is very...
Is there any interest to fixate that wire with a balloon inside deep in the jejunum?
No. Honestly, no. The balloon is we have no balloons that we can inflate through the working channel, so we have to put those balloons over the wire through an over tube, which makes it cumbersome. On the other hand, this is not commercially available. It's only available for research purposes. And if you mean a regular balloon, like a CRE balloon,
Yes, just to fixate the wire inside deep in the jejunum.
yeah, that balloon is not very helpful. It's better to have a naso or orojejunal catheter in place. The only thing we should have been a little bit more careful